Hello, everybody. Hello, everybody. We're getting ready to get started. Just a few minutes more, and we'll be happy to get started. So welcome to today's webinar. We're going to just give it a few more minutes while people sign on, and we will get started right away. Okay, let's just give it one more minute. I did type something into the chat. Just as a reminder, if you have questions that you would like to ask, then please put it in the chat box. We're going to hold off having questions until the end of the presentation, and we're going to get started in 1 minute. Thank you. Okay, I think we're ready to get started. Carrie?
Yes, good afternoon. My name is Carrie Shannard-Kunders, Chair of the NASCA Education Committee, and I'll be hosting this webinar. And I will start my camera at some point in time. I thought I did that. Thank you so much for joining us today for this webinar. I think you'll find it to be very informative and helpful with Dr. Nora Volkov, Director of the National Institute on Drug Abuse. But before I introduce our speaker, I would like to cover a few housekeeping items. Everyone will be on mute during the presentation. If you have questions, the presenter utilize the chat box at the bottom of your screen. We'll pose it to Dr. Volkov at the end of her presentation. Today's webinar is being recorded, and we will be able to share the recording as well as today's PowerPoint presentation shortly after completion. We also invite your comments and questions and ask that you complete a brief survey at the conclusion of today's presentation, which you will receive later. Today's webinar and all of our webinars throughout the year would not be possible without the generous support of our sponsors. We have platinum sponsors, Bamboo Health, formerly Apris, Indivior, gee, my mouth doesn't work today, Johnson & Johnson, MD Scripts, Tyler Technologies, NIC, gold sponsor, we have one, Greenwich Biosciences, and our silver sponsors are Cardinal Health, Hyman Phelps and McNamara, Independent Pharmacy Cooperative, IQVIA, McKesson, Pharma Solutions USA Inc., Rite Aid Corporation, and ScriptSafe Inc. Thank you so much to our sponsors for their generous support. I also have some very important announcements. Mark your calendars. This year's annual conference will be taking place October 24 through 27 at the Marriott Salt Lake City Center in Salt Lake City, Utah. Check the NASCA website for periodic updates. There are several webinars that we will be planning in the coming months. Please check your emails and visit the NASCA website for more details. Check out our latest NASCA podcast. This is on the Pez case, which is Atizalam and the near death of 2 children on Podbean, Spotify, and other podcast platforms. It is excellent, by the way, and very informative. The Bylaws Resolutions Committee is seeking your suggestions for resolution ideas. Please check your state's contact information and ensure that it is accurate and up to date on the state profile section that can be found here at the NASCA state profile section of the website, and contact Kathy Keogh with updates. So moving on to our presentation, we are just very delighted to have our presenter, Dr. Nora Volkov Md, who is the director of the National Institute on Drug Abuse at the National Institutes of Health. NIDA is the world's largest funder of research on the health aspects of drug use and addiction. Dr. Volkov's work has been instrumental in demonstrating that drug addiction is a pain disorder. As a research psychiatrist, Dr. Volkov pioneered the use of brain imaging to investigate how substance use affects our brain functions. In particular, her studies have documented that changes in dopamine systems affect the function of the frontal brain regions involved with reward and self-control in addiction. She has also made important contributions to the neurobiology of obesity, ADHD, and aging. We are very honored to have Dr. Volkov with us today, and our group is excited to hear your presentation. So I'll hand the floor over to Dr. Volkov to start today's presentation.
Well, Anna, it's an honor for me to be here. And so thanks very much for giving me the opportunity to come and speak with you and try to get in a short period, 20-25 minutes, some of the most important aspects that relate to the evidence of our understanding of addictions in general, and also our understanding about how to optimally address, prevent, and treat them. So with that, let me start by sharing my screen, and I will need to know if you see my presentation. Okay, let me see. Can someone tell me, are you able to see it?
Yes,
Yeah.
it's in presenter mode.
Perfect, okay. So I want to just start by reading the mission of NIDA, which is to advance science on the causes and consequences of drug use and addiction, and to apply that knowledge to improve and treatment and public health. I think that we're part of the NIH, and our mission is science targeted to improving issues that relate to substance use disorders. Over many years, research has clearly identified that yes, addiction is a disease of the brain, but it is affected and modulated by multiple factors, like it happens to be the case for many other medical conditions. We know that in addiction, there is a risk that is associated with your genetics. We know of families where basically there is a high density of individuals suffering from addiction. So we know that genes are involved. But we also know that other biological factors influence the risk of addiction, such as when you're first exposed to drugs. And we know that the neurodevelopment, the developmental stages of our lives will connote different risks for addiction if we get exposed to drugs. And very importantly, we know that the environment is crucial and that there are environments that are going to provide resilience against taking drugs and becoming addicted, whereas other environments are going to facilitate drug taking and transition from drug taking into addiction. And by just put the definition that addiction is considered the state in which the individual is no longer able to control the very strong urges to take the drugs, even though they cognitively, consciously want not to do it anymore, and even though they are very aware about their negative consequences. So that inability to control the urges is what characterizes the transition from drug taking into the addictive states. The drugs themselves also are going to be modulating the changes in the brain that ultimately result in addiction. So no matter how much genetics you have, if you don't get exposed repeatedly to drugs, you will never become addicted. But it is also clear that not everybody, as I mentioned, that gets exposed to drugs become addicted. It's also clear that some drugs are much more addictive than others. Among the most addictive drugs that we recognize are drugs like methamphetamine and drugs like fentanyl or heroin. Why is it? They are more potent and they induce changes in the brain much more rapidly than other drugs such as alcohol or marijuana. And to the extent that all of these factors contribute to actually producing these brain changes that produce addiction, we can start to understand why when we are referring to addiction as a disease of the brain, we need to recognize that social and environmental factors are crucial determinants on whether addiction is going to be observed or not. In the perspective of science, we have also learned a lot over the past 2 decades in terms about how, if you have a genetic vulnerability for addiction, why is it that you have it? What does it mean in terms of how the brain works? And so using technologies like different types of brain imaging, it has become possible to determine what aspects of our brain development from childhood into adulthood are dominated by genetic elements to our biology versus our environment that may stimulate or not certain pathways of the brain. And this is a study that illustrates those strategies, showing something that is very interesting and very relevant for us in the addiction field, as well as other interventions of mental health. And that, yes, that genetics actually, in this case, the weight of the genetics, the importance of the genetics is illustrated in different colors from very high to lower in different areas of the brain. This is a plane of the brain at 5, 8, 11, 14, and 17 years. So for example, we see that when a child, a very young child, 5 to 8 years of age, you see more a genetic influence than later on when they are adolescents. But nonetheless, you see a significant effect of genetics in certain areas of the brain, like these prefrontal areas, like these superior parietal cortical areas, like these temporal areas, which are actually quite important for emotions. We can do the same in terms of environment. And these studies have, again, revealed something that is fascinating. Just like we see for genetics, the environment is crucial, and it has the largest impact in the first decade of a life of a child. And you can see this here and here. As the child grows into adolescence, the influence of our environment is much more limited. What does this tell us in terms of its implications? Is if we are going to do interventions related to prevention, to build resilience, to provide environments that are going to support that child is likely, that intervention is likely to have by far the largest effects during that first decade. And also, opposite to this, if you have a child growing in very adverse environments, those environments are likely to have much more pernicious effects if it is during the first decade of their life. The other element that is very important in understanding the vulnerability of this period of our lives in childhood and then transitioning to adolescence is that during this period, there are significant changes on the formation of the brain. The brain is being formed, and the brain is being formed as a function of the context that surrounds it, of the environmental challenges that exist, of the encounters on everyday life. And that's why it takes so long for our brain to develop up to mid-20s, because it needs to optimize its structure and function on the basis of the environment that surrounds the individual. Certain areas of the brain develop much faster than others. Interestingly, and here it is denoted here, if we take basically that development from very little development until full development as a function of age. We see, for example, that this curve here that represents the limbic areas of our brain that are responsible for our emotions actually form very rapidly. In contrast, the prefrontal cortical regions, which are the cognitive elements of our brain, actually those that are here, that allow us to exert self-regulation, are much slower in developing and do not really form until we are in our early 20s. So in an adolescence, there is a disconnect between the completed limbic regions, so they can basically signal and intensely identified emotions and reactions, and the prefrontal cortex that is needed in order to make decisions and to exert self-regulation. And this explains why adolescents are much more impulsive and engage in behaviors, very risky behaviors, much more frequently than later in life. And it is these characteristics that actually account why teenagers are much more likely to start experimenting with drugs and to actually get into behaviors that could increase their risk and well-being. Using imaging technologies, interestingly, it has also been possible for us not just to determine that indeed the environment is very important in your development, particularly during the first decade. It continues to be important in adolescence, but particularly during the first decade, to actually ask the specific question, well, how does an adverse environment, like for example, social isolation, which has been recognized to be a factor that increases the likelihood of drug taking and adverse mental health, how does this environment that has been recognized now for many, many years affect the development of the human brain? And with imaging, for example, it is notable that what researchers have consistently found is that children that are, and this first was studied in children that have been brought up in orphanages, in which there basically a lot of social deprivation. And in these children, the development of the connections between the prefrontal and limbic brain regions that I was just discussing are actually markedly delayed. And this is, of course, going to interfere ultimately with their ability to self-regulation. Similarly, more recent studies that we're doing, thanks to a very large project in which we're following longitudinally 12,000 children as they transition into adulthood, we have been able to address in the United States, how do the adverse neighborhood conditions in which a child lives is going to affect the brain development. And these studies, for example, have also shown that children that lived in very deprived neighborhoods with poor access to schools and community support systems actually have much smaller areas of the brain that are in the prefrontal cortex that are necessary, as I say, for self-regulation and for decision-making. And so through these technologies, it is becoming clear that adverse social environments are likely to be, on the one hand, one of the factors that we should be targeting in prevention, but also one of, again, it's a factor that's malleable, but also identifying too the implications that it has for health disparities in our country. In a recent study that actually takes advantage of this study of 12,000 children that we have been monitoring, we were interested in understanding how the COVID pandemic, which is marked changes in social structure and uncertainty and stress, had on children's behavior for taking drugs, and to identify the factors that actually could help us predict which children would go on to increase drug taking during the COVID pandemic versus those that would not. Not surprising, what the data shows is that the family environment is one of the main contributors to determine whether a child, which these are children 12 to 13 years of age, so they are quite young adolescents, will initiate drug taking or not. So if the parents actually smoke cigarettes or take cannabis, these children are much more likely to initiate drug taking. Also, to the extent that these children perceive stress, anxiety, and depression, they're much more likely to initiate drug taking. And I think that these are clear lessons that help us identify how to optimize prevention interventions. And we know from years of research on prevention that prevention works, and that the level of prevention, whether it is universal, an intervention that is used for all children to provide resilience, or targeted intervention that actually identifies, for example, children that have depression or anxiety, which are at greater risk of actually developing substance use disorders, to tailor the intervention to counteract those vulnerabilities. So in simple terms, what we have known all along is prevention works. And the prevention is based on decreasing all of the risk factors that we were discussing, which include adverse family environments, community environments where drugs are very accessible. Actually, poverty. Poverty is a risk factor because it increases the likelihood of encountering social stressors. On the other hand, we can basically, prevention interventions should enhance the protective factors that we know. And one of the most important protective factors that we have in children, adolescents, and adults is that of meaningful relationships, supportive relationships. So to the extent that we can do interventions, and there are evidence-based interventions that help us identify how to enhance those social meaningful relationships, taking advantage of the families, of peers, of schools, of communities, we can actually deliver interventions that can have a very large effect in terms of preventing drug taking in the child, in improving mental health conditions. And some of these studies have even shown that it has a generational effect, that the intervention not just improves the outcome in the child that was targeted, but also in the children of those children. But the problem is, as we build up, and this research has been built up, is that it is not implemented. The evidence-based interventions of prevention are basically underutilized. So as we look forward into the future, it just behooves us to try to actually realize that we need to put this as a priority and identify the resources and support systems that will enable their implementation. So with that as a discussion on prevention, let me jump then into the COVID pandemic and how it has affected the landscape of substance use disorder in our country. We knew to start with that individuals with substance use disorders, because of their social circumstances and also because of the adverse effects of drugs on multiple organs and systems in our body that are attacked by the virus, like the lungs, the heart, the immune system, they are affected by drugs. So we were concerned, and others have been, that individuals with a substance use disorder would be at greater risk, on the one hand, to get infected because of their unique social circumstances, but also if they got infected, we were concerned that they would have worse outcomes. And using a very large database of electronic health records, this study was able to document indeed that individuals with a substance use disorder, whether it is alcohol, cocaine, cannabis, opioid use disorders, or tobacco, so whether it is legal or illegal, these individuals that have actually a substance use disorders had a much higher risk of contacting and getting infected with COVID than those that did not have substance abuse issues. And this is the relative adjusted risks for these individuals. As you can see, they are very large. So the risks are much greater. Then the question came around, if you do get infected and have a substance use disorder, what's the likelihood that you will have adverse events? And here you have the mortality in the United States at the beginning of the pandemic when people got infected of their chances to die. And you can see what attracted the attention very early on, that African Americans were much more likely to die than Caucasian. And that disparity continues as the pandemic has evolved, but fortunately has started to decrease, but it's still there. When we look at the risk of death, though, for people that have a substance use disorder, we see that it is significantly higher than those that do not have a substance use disorder. And we also see that this disparity between Black Americans and white Americans is actually even more accentuated, indicating that in these very vulnerable individuals, and we now know that their vulnerability for dying relates to the fact that individuals with a substance use disorder have much higher levels of comorbid and chronic medical conditions that therefore makes them much more vulnerable to dying from COVID infection. And these chronic medical conditions are worse in individuals that are Black Americans, again, highlighting the devastating consequences of social inequity and the need to provide healthcare, evidence-based healthcare, of quality for everyone. As it relates to the opioid crisis that we were been struggling for the past 2 decades in the United States, and which prior to the COVID in 2019, we have not been able to control. The question was, what happened with the COVID pandemic? When the stressors actually increased dramatically, including social isolation, or community support systems that provide a means for people with a substance use disorder to actually achieve some level of protection were closed, where systems that provide them with treatment were closed. What happened to them? So we were actually very concerned about their pattern, not just in terms of getting infected from COVID, but also what about their drug taking? And we know overall that drug taking has increased across America. And this has to basically include increases in alcohol drinking, increases in use of cannabis. Now to the question of opioids and other drugs, where are we now? Well, this is data from 2020 that actually shows the total drug seizures across the whole United States, starting in year 14, 15, 16, 17 until year 20. And you can see that between 2019 and 2020, there is a significant jump in the number of seizures from cocaine, but it was already going up in 2019. Look in turn to methamphetamine. There you see a dramatic increase in the seizures from methamphetamine from 2019 to 2020. There's not much change in heroin, but look at fentanyl. Fentanyl have been stepping up, rising, and this has been of tremendous concern, but it made an even bigger jump between 2019 and 2020. So these two indicators basically are telling us that the distribution of these drugs, methamphetamine and fentanyl, was massively expanded during the first, certainly this is data from 2020, the first year of the pandemic. It is expected that similar numbers are occurring during the 2021. So when one looks at how does that relate to the changes in overdose deaths, which we already were very concerned in 2019 because they have been keeping up rising and we have not been able, except for 1 year, to decrease them. The question is, how did they increase? And so here is data that I have from the CDC. The latest numbers that have been released from there are on June 2021. So it records the number of people that died on the 12 months that end on June 2021. And this number caught a lot of attention because it indicated for the first time in the history of the United States that overdose deaths has surpassed 100,000. This was a horrible milestone to achieve. And this was, of course, over deaths that have already been very high in 2020, 3 months after the initiation of the pandemic. This resulted in, over that period, in a 20% increase, close to 21% increase. And when one goes and looks at what are the drugs that accounted for most of these increases in overdose deaths between 620, the 12 months preceding it, and the 621, the 12 months preceding it, we identified again the two major culprits, fentanyl and analogs, and the other one is methamphetamine. So these two drugs, extraordinary potent, extraordinary toxic methamphetamine, and fentanyl with an extremely high risk for overdose mortality, account about why, when they get expanded into the population, why they get expanded, because they actually you can manufacture it in the laboratory. It's not a complex synthesis. And so they are much more profitable. The revenues are much greater for the illicit market to actually develop and sell these drugs than to sell drugs like cocaine or heroin that require cultivation. And it does, I am reiterating on this, because of the profits that the legal market can make with these synthetic drugs, and methamphetamine is a synthetic drugs, are so gigantic that we should be prepared to see these as the major challenges of drugs available for people to consume into the future. What are the strategies that we currently have to address the current crisis with overdose deaths? Well, we have therapeutic interventions that work, and the evidence shows that they work in terms of preventing overdose deaths, and they work also in terms of helping people achieve recovery. In terms of preventing overdose deaths, we know that the #1 intervention that has been shown to have the largest effect in preventing deaths is the distribution of naloxone, widespread distribution of naloxone. Naloxone is, I like to call it, almost a miracle drug, that if you give it to someone that has overdosed, even if the overdose is fentanyl, if you give it in time and at a sufficient dose and sustain that dose, you can save that person's life. The challenge is, of course, that naloxone is not always available, that doses are inadequate, or when the person actually that's going to be administering the naloxone arrives, time has passed and he no longer, or she no longer can administer it. You need to act rapidly. So the interventions we know that we need to push forward in terms of policy is to ensure that naloxone is widely available and free for everyone. My perspective is that naloxone should be distributed like we have been distributing vaccines, or like we are now distributing tests at no cost and widely to the individuals. Medications to actually also help prevent overdoses. And not only do they help prevent overdoses, they also help achieve recovery. We have 3 medications: methadone, buprenorphine, and naltrexone. They are different, each one of them, and each has advantages and disadvantages. And all of them basically have been shown that if you are using these medications for the opioid use disorder, you dramatically reduce the likelihood of the person overdosing and dying. The challenge, again, just like prevention or naloxone distribution, is that they are not widely available. And the other challenge is that people that are taking these medications still have a high risk for relapse. Between 50 and 60% will relapse at 6 months. And thus, we need to actually ensure that we have a support system that enable these individuals to stay in treatment. As long as they stay in treatment, they will not relapse. As long as they stay in treatment, they will not overdose. So what is it that we can do to support them in sustaining treatment? I'm just going to identify how important these medications are and interventions. This is a small study that actually was recently, it's a small study in that it represents only 2 jail systems. One of them which had initiated buprenorphine in jail, and the other one is comparing it also in Massachusetts, where they have not started the initiation. So it allows to compare by comparing the outcomes in these two jail systems, which are rural, by the way, you can actually determine the impact that the buprenorphine had. And what's interesting is that others had shown, and several studies have shown that initiating treatment in jail basically prevents relapse into drug taking and protects you against overdosing. Several studies have shown that. There's no really questioning on that. But this is the first study that has shown not only do you prevent relapse and you prevent overdoses, but in this case, they actually showed that buprenorphine reduced the recidivism of these individuals, and it also decreased the number of those that were rearranged. So as one thinks forward in terms of cost-effective interventions, it is hard to justify why would we not be expanding the utilization of these medications in justice settings. So we've established collaborations and partnerships across the United States with justice settings in order to try to disseminate and engage with them in best practices to apply these advances. There are many ways in which we interact with the currently available systems. For the justice system, for example, we have created a network, which we termed the Justice Community Opioid Innovation Network, that enables us by creating blending of researchers with sort of people involved in justice system themselves to understand what are the challenges and how to implement treatment approaches. The other major structure that we have as a nation for addressing substance use disorder is healthcare. A lot of the treatments rely very much on the specialized treatments, but specialized treatments are much more expensive and absolutely insufficient to account for the needs of people all throughout the United States. And yet the healthcare system is there, and we should be using it to do screening and treatment on people that have problems with opioid use disorder. The data shows that interventions that initiate medications of opioid use disorder in healthcare settings, whether it is primary care clinicians or whether it is actually emergency department, result in as good outcomes as those that actually are initiated by specialized treatment centers. And ultimately, we through these the healing community studies, we have developed a model to maximize ways in which we can facilitate the interaction between healthcare systems, justice settings, and communities to deploy the prevention and therapeutic interventions to address opioid use disorders. I want to end my presentation with a very, very simple message, and it is actually because it is at the essence and at the basis of a very powerful tool that we have for addressing substance use disorder. This is a picture of someone taken during basically of someone injecting heroin, and they were illustrating this time special report was illustrating the opioid crisis. And it caught my eye because of the horrific isolation, the loneliness of this person. And it basically resonates with what we know with very simple animal experiments, that if you put an animal, a little rat, that's usually the way you do it, with two levers. In one lever, they can administer drugs. They can be heroin or methamphetamine, the most addictive drugs. And in the other one, a lever that allows them to interact with another rodent. And when you give them the choice, they have a choice, they do not take heroin. They basically press the lever to get the social reward. However, if you penalize the social reward, in the case of the rodents, you basically can put a small electric shock when they touch the lever. And in the case of humans, you basically can discriminate and mistreat someone. So if you penalize the social interaction, see what happens. Drug taking goes up and social interactions decreases, and the individual isolates themselves. So the lesson learned from this very simple experiment and from the reality of what we are observing is, as we face the overdose crisis, we need to recognize that we need to address its causes, which actually relate very much to the social isolation and the lack of purpose that people in many places are feeling. And to the other, in terms of the treatment, that the most powerful treatment interventions that we can do, actually, in order for them to be sustainable and to support that person into require, need to take advantage of creating meaningful social interactions. And for that to happen, of course, we need to work together in terms of regardless where we are coming from, healthcare, justice, or community. And with that, I want to thank you for your attention, and I'll be happy to answer any questions if you have them.
Dr. Volkov, thank you so much for sharing your insight and expertise with our group and providing this excellent and informative presentation, answering some questions we've all had, I think, about the level and how COVID has affected overdose deaths and all of that, and just the general use of drugs. So I appreciate that. Kathy, do we have any questions in the chat?
Yes, and actually I had one myself as well, but I'll wait till the end. So some of the slides seem to show age groups with COVID-related increases in substance abuse disorders, but the MTF results from December show significant decreases in adolescents and teens. What can this be attributed to? Effective prevention efforts?
No, the monitoring the future effectively, which actually is gets information related to drug use in 8th, 10th, and 12th graders, and it's a survey that's done based on the school, show the most dramatic decrease in drug taking among adolescents ever during the last year. So it was 2021 showed the largest decreases we've ever seen. And this was basically true for legal and illegal drugs. You see it for alcohol, you see it for cannabis, and you also see it for even nicotine vaping, which had been going out in the past years. The explanation that is likely to account for this dramatic reduction in teenagers is that in teenagers, drug taking is very much a peer pressure behavior. Teenagers take drugs and experiment when others are around, and they want to be part of the group. So to the extent that actually teenagers did not have an opportunity of interacting with one another, they were much less likely to engage in drug taking. So this is the explanation that we believe accounts for this dramatic reduction. At the same time, we need to, it basically poses the question that as teenagers go back to school, if this is correct, we should basically expect that the rate of drug taking to go back to what it was just before the COVID pandemic. But we also need to be cautious as we go back, because we also realize that in some teenagers, the pandemic has been particularly stressful. So the levels of anxiety and depression, which we know increase the risk of drug taking as a way to auto-medicate, may then emerge as an issue. So we need to be mindful that what we are observing right now is likely to reflect the fact that teenagers have much less opportunity to actually get drugs because they get them from their friends, and also to have the behavior of mimicking, of copying others in order to be accepted into the group. And also, again, my concern, like that of many others, is that we are going to see a greater disparity between teenagers that have the support to actually be able to advance in their education versus those that came from low-income families where both parents are working, where their education suffer more, so that we will generate a greater gap, and that in turn also puts them at greater risk of anxiety and stress and failures at school.
Okay, another question regarding methamphetamine. Sam Quinonez's latest book suggests that a change in the illicit synthesis procedures for methamphetamine P2P has resulted in increases in brain toxicity and severe mental illness, sometimes irreversible. Does your data support this?
Well, it's an interesting concept, and he brings to the light to me what is very important, which is to a certain extent neglecting, recognize how widespread the expansion of methamphetamine has been. And who is most vulnerable in this case? It's the homeless individuals that appear to be the most vulnerable. Methamphetamine has always been recognized as being highly toxic drug. It damages the blood vessels, it damages tissues, it makes people psychotic. The extent to which this new synthesis results in greater toxicity has not per se been investigated. To the extent that this new synthesis leads to greater number of contaminants, you could also understand why that will lead to even greater toxicity. But it is clear, methamphetamine is among the most dangerous drugs that we know of. Heroin and fentanyl are dangerous in that they actually directly inhibit respiration. They just stop breathing. And if you stop breathing, then you die. Methamphetamine, in turn, damages all of the tissues in your body. It promotes arrhythmias, and people die from malignant heart arrhythmias. And so when you start to think about it, and you see what people have been commenting, I didn't discuss very much, but more and more we're seeing people dying, not just from one substances, but multiple substances. And people that die from methamphetamine, 75% of them also have fentanyl is reported as fentanyl as a contributing substance. So 75 are a combination of methamphetamine and fentanyl, which reflects the increasing contamination of all illicit drugs with fentanyl. And again, this is motivated by profit. You make much more money if you sell fentanyl than if you sell almost any other drug.
All right. Can you discuss evidence-based interventions?
Yeah, evidence-based interventions actually exist in general for all of the substance use disorders. For opioid use disorder, the strongest evidence, the one not just with the strongest evidence, but also with the largest impact, is initiating on medications for opioid use disorder. Whether you do it by itself or jointly with support of behavioral therapies, it is extremely beneficial. And again, it has the largest effect. And as a result of that, the National Academy of Sciences had a report that actually concluding that not providing access to medications for opioid use disorder is actually deleterious, that there is absolutely no justification not to do it, and encourages clinicians and treatment providers to initiate medications for opioid use disorder. One of the challenges has been that some clinicians, because it was required that you provide the behavioral support, did not have the capabilities to provide with that behavioral support. Yet the data unequivocally shows that even without behavioral support, the advantages of initiating the buprenorphine treatment or methadone treatment outperform not doing it because you don't have the behavioral support. So there's absolutely no justification not to expand as much as possible access to medications for opioid use disorder with proper oversight. And I'm identifying this because one of the concerns that we have in the treatment field is that because there are resources now to help pay for treatment, we have seen new treatment programs emerge with no concern for quality. And therefore, in those instances, it can result to negative outcomes. And we've also been concerned, of course, that there may be diversion of medications used for opioid use disorder for the Black market. And then that also could negatively affect the impact of individuals. So yes, implementation of medications for opioid use disorder, provided that there is a quality control and oversight about the access to these treatments. This is the most powerful intervention.
Is your organization funding any programs towards promoting prevention in the first decade of life aimed at reducing prescription opioid availability?
Well, absolutely. We've been funding and we continue to fund because it's so important. Our interventions, though, for prevention of substance use disorder don't target one drug. We target basically drugs in general. And this is because you may base it, if you target, so say, for example, prescription medications, a teenager may start using smoking or cannabis or nicotine. And then that in itself actually primes them later on to use these drugs. So universal in that respect, universal prevention towards behaviors that are healthy, and teaching children about how to refuse pressure from other teenagers for experimenting with drugs, interventions to actually help them exert self-regulation. All of them have been shown to benefit basically prevention of all types of drugs, whether it's prescription drugs or whether it is cannabis or nicotine.
So I'm just going to ask my own question. I've read a lot about magic mushrooms, some of the drugs that are Schedule 1 drugs that seem to be indicating some promise. And I'm wondering if you could speak to, that and where you see the future is in some of the drug therapies.
Yeah, and this is very interesting, a very interesting area of research, whether it is, I mean, the terms of, they call these drugs psychedelics, or others like to call them hallucinogenics, but really they are not all of them are hallucinogenics. But interest in the potential therapeutics of this type of drug came about because it is actually one of them, ketamine, actually has been shown to be beneficial for the treatment of resistant depression. And it has been approved by the FDA for treatment of depression. And again, this is a drug that in certain countries is one of the main drug of abuse. And but nonetheless, when used in appropriate setting for a very specific intervention, it can have therapeutic promise. There's also interest on evaluating the benefits of other medications like PCP for the treatment of post-traumatic stress disorder, or also even for the treatment of addictions. And to the extent that there's actually, and there is behind it, what our understanding about these drugs is that they have the capacity, this is what is being hypothesized based on what has been observed in animal models, to actually promote plasticity in the neurons. So plasticity actually can result in neurons strengthening themselves, which happens when we learn something. But these drugs can, for example, help accelerate that, as well as help you weaken other competing memories. So researchers are therefore trying to understand how to optimally use these interventions in parallel with behavioral interventions that actually they want to modify by the use of these type of drugs. And so there's a lot of interest. It's a very, very early area of research. And like anything else, it always generates sometimes an expectation that is basically everybody starts to think about these as the miracle drugs. And it's unlikely that they are going to be the miracle drugs, but it is very likely that they have potential for therapeutics, and that they may also help us give us an understanding on how to actually modify these molecules in ways that we can actually take all of the benefits that they observe and minimize the side effects.
Okay, and I think we have time for one more question. Unrecognized and undertreated trauma fuels isolating behavior through depression, anxiety, fatigue, chronic pain, and more, and interferes with socialization efforts in kids and adults. To what degree is the HEAL focused on trauma recognition and treatment?
Yeah, no, and this is a very important point. And absolutely, the data has shown that interventions that can heal, that actually are targeting towards helping a person heal and recover from the very negative effects that trauma has on an individual life, is crucial. And it's crucial not just for substance use disorders, but for other mental illnesses. So working on interventions, identifying also by screening whether there is a history of trauma or not, is one of the processes that's necessary to actually then personalize the therapeutic intervention for that individual.
Okay, thank you. And I think that's all for questions.
Okay, thank you, Dr. Volkov. very interesting, informative. I think our group is thrilled we've had you here today. So to close, I think I need to tell you on behalf of the National Association of State-Controlled Substance Authorities, I would like to thank everyone who joined us for today's webinar. And thank you again to Dr. Volkov. Again, thank you to our sponsors for making today's webinar possible. And thank you for your time, and have a wonderful rest of your day.
Well, thanks for having me, and goodbye, everyone.
Thank you.
Thank you.